Every time you read a study and consider applying its findings to your patients, you're asking two questions, whether you realize it or not. First, can I believe this result? Did this study measure what it claims to measure in this population without fatal methodological flaws? That's internal validity. Second, even if I believe it, does it apply to my patient? Is my patient similar enough to the study population that the findings are transferable? That's external validity. These two questions are sequential. External validity is irrelevant if internal validity is poor. A study that got the wrong answer for its own population certainly can't help you with yours. But a study with excellent internal validity may still not apply if the study population is too different from your patients. In this talk, we'll build both concepts carefully, connect them to sampling and representativeness, and give you a practical framework for applying study findings to individual patients and populations. These are the skills that turn evidence into clinical action. Internal validity is the foundation. It asks, did this study accurately estimate the association between the exposure and the outcome in the specific population it studied? Not in your population, in the study population. A study has high internal validity when its methods are sound. The right animals were enrolled and kept in the study, measurements were accurate, confounders were controlled, the sample was large enough to distinguish signal from noise, and the analysis matched the data type and design. When any of these are compromised through selection bias, information bias, uncontrolled confounding, insufficient power, or statistical misuse, internal validity suffers. The threats to internal validity are exactly the threats we covered in Units 4 and 5. Bias and confounding are the major structural threats. Chance is addressed through sample size and power. This is why bias analysis, confounding identification, and power assessment are all part of critical appraisal. They're the tools for evaluating internal validity. Here's the key conceptual boundary. Internal validity is entirely about whether the study got the right answer for its own population. A perfectly valid study of thoroughbred racehorses tells us nothing about miniature horses, and that's not a failure of internal validity. That's an external validity question. The two concepts operate at different levels. External validity, also called generalizability or transferability, is a question of whether the study's findings apply beyond the specific population and context where the study was conducted. This is a clinical judgment, not a statistical calculation. No p-value or confidence interval tells you whether the findings generalize to your patients. The questions you need to ask are practical and contextual. Is your patient similar to the study population in the ways that matter? If a study enrolled only Labrador retrievers and your patient is a dachshund, the breed difference may or may not matter depending on the disease and intervention. Is the study population broadly representative of the population you're treating, or was it highly selected? Referral cases, single breed, narrow age range, no comorbidities? Common reasons findings fail to transfer. The study was conducted in a referral or tertiary population where disease severity is higher and case mix is different from general practice. The study excluded animals with comorbidities, but your patient has 3 concurrent conditions that were all exclusion criteria. The study was conducted in a specific geographic region with a particular pathogen environment that doesn't match yours. The intervention required a level of monitoring or specialist access that isn't available in your setting. The Venn diagram captures the key insight. External validity is about the overlap between the study population and your patient or population. The wider the gap, the more caution is warranted in applying the findings. When the gap is large, you have several options. Look for additional studies in more similar populations, apply the findings with explicit acknowledgement of the uncertainty, or recognize that you're extrapolating and make clinical decisions accordingly. The mechanism that determines external validity. How you select your study sample from the target population determines whether your findings can be generalized back to that population. The sampling frame is the defined list or group from which participants are actually drawn. If your target population is all dairy cows in Wisconsin, but your sampling frame is cows at farms enrolled in a DHI cooperative, your findings apply most directly to DHI enrolled farms, which may differ systematically from non-enrolled farms in herd management, production level, and data quality. Probability sampling methods, where every individual or group has a known non-zero probability of selection, are the foundation of representative sampling. Simple random sampling gives each individual an equal chance. Systematic sampling selects every nth individual from an ordered list. Efficient, but can introduce bias if there's a periodicity in the list that aligns with the sampling interval. Stratified sampling divides the population into meaningful subgroups, age groups, breeds, regions, and samples within each stratum, ensuring representation across all subgroups. Cluster sampling randomly selects groups, herds, farms, schools, then enrolls animals within selected clusters. This is common in veterinary field epidemiology, where individual animal lists don't exist, but herd lists do. Non-probability sampling, convenience samples, voluntary respondents, limits external validity because the sample is inherently self-selected. Farms that volunteer to participate in a study are different from farms that don't. They're more likely to have good records, engaged owners, and above-average management. Clinic patients differ from animals that never see a veterinarian. These differences may be irrelevant or critical depending on the question, but they always need to be acknowledged. The relationship is direct. A more representative sample produces higher external validity. This is why sampling design matters as much as study design. A beautifully randomized trial on a convenience sample may have excellent internal validity, but very limited generalizability. Based epidemiology introduces a specific validity threat that deserves its own discussion: non-response bias. Non-response bias occurs when the animals, owners, or producers who respond to a survey differ systematically from those who don't, and those differences are related to the survey topic. In our antibiotic use example, a survey achieves a 35% response rate. The 35% who responded are, by definition, those who were interested enough in the topic to complete and return the survey. People interested in antibiotic use practices are more likely to be engaged with stewardship principles, meaning the respondents are probably more thoughtful about antibiotic use than the average non-responding producer. The survey's picture of stewardship practices will be rosier than reality. Response bias is different. It's not about who responds, but about the accuracy of their responses. Social desirability bias is a major concern in surveys about regulated or stigmatized behaviors. Producers who use antibiotics in ways that might draw regulatory attention are likely to underreport those practices on a survey, even an anonymous one. The measurement is systematically wrong in a direction that flatters the respondent. How do you evaluate non-response bias? If you have any information about non-responders through registration data, prior records, or a brief non-response survey, compare their known characteristics to responders. If they look similar on measured characteristics, non-response bias may be less severe. If they look different, the concern is heightened. The practical rule: always report response rates. A response rate below 60 to 70% in a survey should prompt explicit discussion of non-response bias and possibly a sensitivity analysis examining what the results would look like if non-responders had systematically different views. The most important and most underappreciated concepts in research design is that internal and external validity frequently trade off against each other. Design choices that strengthen one often weaken the other. Strict inclusion and exclusion criteria improve internal validity by reducing confounding and heterogeneity. You're studying a more uniform population where the exposure-outcome relationship is cleaner. But that same strictness reduces external validity. The carefully selected study population is increasingly unlike the real-world patients you're treating. Highly controlled laboratory settings maximize measurement precision and eliminate environmental noise, excellent for internal validity. But real clinical practice is messy. Animals are stressed, owners give medications inconsistently, comorbidities are common. The lab result may not translate. This trade-off has a name in clinical research: efficacy versus effectiveness. Efficacy trials, sometimes called explanatory trials, ask, does this intervention work under ideal conditions? They prioritize internal validity, strict protocols, selected patients, close monitoring. Effectiveness trials, sometimes called pragmatic trials, ask, does this intervention work in real-world practice? They sacrifice some internal validity to gain external validity, broader patient populations, routine care settings, flexible protocols. Both questions matter. An antiparasitic drug that achieves 100% efficacy in a controlled challenge study is clinically useful only if it also performs well when owners give it inconsistently to dogs with variable parasite loads under real-world conditions. Efficacy establishes mechanism. Effectiveness establishes utility. For a new treatment to earn a place in clinical practice, you ideally want evidence from both types of studies. Let's put all of this into a practical framework you can actually use when reading a paper and deciding whether to apply its findings to your patient or population. Step 1. Is the study internally valid? Run through the bias and confounding checklist. Is the sample size adequate? Were appropriate statistical methods used? You're asking, did this study get the right answer for its own population? Step 2. What is the magnitude and precision of the effect? Don't stop at p-value less than 0.05. Look at the effect size, RR, OR, HR, mean difference, and its confidence interval. A statistically significant finding with a clinically trivial effect size and a wide confidence interval is very different from a significant finding with a large effect size and a narrow CI. Step 3. Is your patient similar to the study population in ways that matter? Consider signalment, disease stage, comorbidities, and setting. The more similar, the more directly applicable the findings. Step 4. Were important subgroups excluded that describe your patient? If the study excluded animals over 10 years old and your patient is 12, you're extrapolating outside the study's domain. Step 5. Is the intervention feasible in your setting? A treatment requiring continuous ECG monitoring isn't applicable in a rural mixed practice setting. Step 6. What does your patient or client value? Does the benefit-harm profile, NNT and NNH, align with what they're willing to accept? Step 7. Apply the evidence and be explicit about where you're extrapolating. This recommendation is based on evidence from a referral hospital population. Our patient differs in these ways, which introduces additional uncertainty, is an honest professional statement of humility. It's not a failure, it's good medicine. Summary. Internal validity asks whether this study got the right answer for its own population. It's threatened by bias, confounding, and insufficient power. External validity asks whether the findings apply to your patient or population. It's a clinical judgment driven by the similarity between the study population and yours. Internal validity is the prerequisite. A study that got the wrong answer for its own population can't help yours. Sampling frame and sampling method determine representativeness. Probability sampling maximizes it. Non-response and response bias are specific threats in survey research. The internal-external validity trade-off is real and unavoidable. Efficacy and effectiveness studies answer different questions and both matter, and applying evidence to individual patients is a structured, seven-step process that ends with explicit acknowledgement of uncertainty when extrapolating beyond the study population. In the next talk, we cover the practical skills of critical appraisal, reading papers systematically for quality, along with reporting guidelines, intention to treat analysis, and per protocol analysis. Pause the video, read the scenario and questions, and try to answer them. We'll then work through the answers together. Question 1, internal validity assessment. Strengths, randomized design. Controls, known and unknown confounding. High follow-up rate, 94%. Minimal loss to follow-up bias. Adequate sample size, 120 calves. Likely powered to detect a 40% reduction at this baseline incidence. Clear outcome, diarrhea, presumably defined objectively by fecal score or veterinary diagnosis. 2 farms, somewhat broader than a single farm study. Potential weaknesses, only 2 farms in California. Limited diversity in management conditions. If randomization was done within farms, farm-level practices are controlled. But if allocation was by farm, only 2 randomization units is very limited. Exclusion criteria removed high-risk calves, low birth weight, dam mastitis. These are calves most likely to benefit from or be harmed by the intervention. Whether blinding was achieved is not stated. If calf managers knew which calves received the probiotic, observer bias in fecal score assessment is possible. Overall, reasonably strong internal validity for an RCT with key question marks around blinding and farm-level randomization. Question 2, external validity for the Montana beef producer. Multiple important differences. Breed, Holstein versus Angus cross. Nutrition, pasteurized waste milk versus nursing dam. Housing, individual California hutches versus outdoor Montana pastures. Geography and season, California commercial dairy versus Montana spring calving beef operation. Conclusion, external validity for this producer's situation is limited. The study population and its operation differ in breed, nutrition source, housing, climate, and production system. Question 3. Additional study needed. A pragmatic effectiveness trial conducted across diverse production systems, beef and dairy, multiple breeds, multiple geographic regions, varied housing and nutrition systems, with flexible protocols that reflect real-world implementation. Question 4, NNT and 7-step framework. ARR equals baseline risk and control minus risk with probiotic equals 35% minus 0.6 times 35% equals 35% minus 21% equals 14% equals 0.14. NNT equals 1 divided by 0.14 is 7.1 or approximately 7. You would need to treat approximately 7 neonatal calves with a probiotic to prevent 1 diarrhea case. Given the significant differences between the study population and this producer's calves, extrapolation requires explicit acknowledgement of uncertainty. A reasonable recommendation. The evidence supports probiotic use in neonatal dairy calves in controlled settings, with an NNT of approximately 7. The applicability to Angus cross pasture-raised calves is uncertain. A monitored trial on the producer's own operation would give the most relevant data.